So let's start with the first session with Professor Lorenzo Carpetta. Professor Lorenzo Carpetta is the Associate Professor of Respiratory Diseases, University of Florence, Director of Educational Program in Interventional Pulmonology, Scientific and Website Director of the EABIB, and National Reagent of the WAPIB University Hospital of Carigi, Italy. He's gonna talk today about tracheomalacia, excessive dynamic airway collapse, and role of dynamic bronchoscopy. Please start.
Thank you. Good morning. Thank you for your invitation for the second time in Egypt, in this wonderful city of Cairo, for the first time for me. And I have the opportunity to know many colleagues, very, very nice and expert. The topic that Ahmed gave me, is about tracheomalacia and EDAC. And it's a very interesting topic because trachea is an hidden organ. Sometimes we ignore the pathology of trachea. And tracheomalacia and EDAC are two diseases very ignored. I will give you the definition of tracheomalacia and EDAC, the causes, the diagnosis, the severity evaluation, and treatment. When we speak of tracheomalacia and EDAC, I like to go ahead, but doesn't work. Okay. We speak about the large airway collapse. And there are two terms. The TBM, the term tracheobronchomalacia, is strictly defined as a pathological weakness over the cartilaginous airway wall. And the term EDAC is used to describe an exaggerated imagination of the posterior muscular tracheal membrane during expiration. And the symptomatology is, the clinical, is consisted in barking cough, exertional dyspnea, and frequent respiratory tract infection. The prevalence is very high. For this, I say that is a ignored organ, is an ignored pathology, because in meta-analysis they found that 70% of healthy subjects and 27% of patients with chronic airways disease are classified as having EDAC or TBM, using the threshold of the diameter of below 50% of obstruction. But the most reported approach for the diagnosis is CT scan. The origin are many. So the first thing is to find the origin to treat the primary disease. For example, after tracheostomy on endotracheal intubation, or unrecognized tracheobronchial fracture, chronic irritation of the airways for COPD, for example, impairment of blood supply, inflammation, for example, Wegener syndrome or relapsing polychondritis, destruction of the cartilage for malignancy or iatrogenic, mechanical factors, extrinsic compression from esophagus, from mediastinal goiters, tumors, etc. And very important also the congenital EDAC in the Mounier-Kuhn syndrome. I will show you one case of our hospital. We follow these flow charts. for the management of TBM and EDAC. First of the clinical examination with the history. It's very important, for example, an history of COPD or a history of tracheostomy, closure of tracheostomy. First of all, we evaluate the functional status, the spirometry and flow volume loop. This is typical of tracheal stenosis with a plateau in inspiration and expiration. And this after this obstruction, as we say yesterday with you. And this is a spirometry of extrinsic of EDAC with the fall of the expiration after the peak expiration flow. And if you have the suspect of TBM or EDAC, you have to perform two tests. First of all, a dynamic respiratory CT scan, but also a dynamic bronchoscopy. What is the difference? In 41 studies, this is the last study published in 2021, they included 41 studies of TBM and EDAC where CT scan was the preferred test for diagnosis. Only 3 studies reported bronchoscopy findings. That is the gold standard. It's very strange, this. Yes. And we have to use more bronchoscopy for this diagnosis. And the majority of the CT scan protocol described utilizing a helical or spiral CT technique, and the remaining studies with sign acquisition. What is the difference of the diagnosis with bronchoscopy versus CT scan? There is a big difference because maybe they are complementary. But bronchoscopy gives a direct isolation of the airway mucosa, can perform in critical ill patients at the bedside, and there is no problem of radiation. But the CT scan have the advantage that has the ability to obtain a large amount of data in only a few seconds compared to bronchoscopy, and there is the possibility to have a dynamic with a sign MRI. The cons is that there are no details about the mucosa, reveals adjacent parenchyma vascular structures, but this is an advantage, and require the patient cooperation and exposure to ionizing radiation. These are some examples of comparing CT scan of EDAC with bronchoscopy, and others with also other windows. And dynamic bronchoscopy is considered the gold standard approach to lac diagnosis, and it permits a real-time evaluation of the dynamic airway properties, asking to the patient to expire, asking to the patient to cough, and so permit repeated and sequential assessment during different maneuvers. Allows airway sampling, but dynamic bronchoscopy have a poor standardization. In the last year, many authors tried to give more standardization. With this article of 2014, that was the a pilot study about the dynamic bronchoscopy, where they gave a standard of still images during the bronchoscopy in 5 sites. Proximal trachea at the level of the cricoid, mid-trachea, 5 centimeters proximal to the carina, distal trachea, 2 centimeters proximal to the carina, right main stem, and left main bronchus. This is the example. And they measure, or they gave a judges about the presence or absence of tracheomalacia and the severity in these 5 sites. The problem is that after this pilot study, nothing happened. So now we have no more application of dynamic bronchoscopy, but we have a very good standardization of the severity classification. What is, and we will see how. What is the initial evaluations, especially with bronchoscopy? Is it fixed or dynamic obstruction? Is it a tracheobronchomalacia or ADAC? Is it focal, multifocal, or diffuse? Mild, moderate, or severe? Does impact patient's functional status? How much? And what is causing it? And we have to answer to these questions to decide the treatment. And after this, we can decide if it's a NADAC or a tracheobronchomalacia. And we try to have a standardization with a famous classification proposed by Professor Murgu, Professor Colt, that consider functional class, extent, morphology, origin, and severity. Some examples for the functional class: the WHO classification on limitation of usual physical activity. For extent, normal, focal, multifocal, or diffuse. These are some examples. The classical ADAC is a crescent ADAC in the second images, expiratory, and the TBM is fixed. TBM crescent is very, very severe. Severity, normal, mild, moderate. The cutoff is between mild and moderate, is 50% of obstruction. This is an example of a morphometric measurement, and we go to the treatment. Treatment of ADAC could be conservative with bronchodilator, CPAP, and etiologic treatment. Semi-invasive, if we consider bronchoscopic treatment semi-invasive, with stent or with laser. And surgical with tracheostomy, sleeve resection, and stectal reinforcement and external stents. If it is a bronchomalacia, we have seen yesterday a case of a tracheobronchomalacia with obstruction. Consider sterting section or surgical resection. This is an example. You can decide if it's possible. You can do surgery, okay, resection, and if it's not possible, you can put a stent. And if is a ADAC, consider first of all conservative treatment with non-invasive ventilation with the CPAP, and there are some studies that demonstrate the efficacy of CPAP, positive pressure ventilation, but the problem is that CPAP could create or worsen TBM. Stenting, there is a big discussion about the opportunity of stenting. This study demonstrated improvement in clear functional status, stent and severity of airway collapse. Actually, we have many kind of stent, Y stent or cylindrical stent. Better to use the silicone stent because you can remove easily after some times. There is the strong recommendation FDA not to use metallic stent in the benign diseases. This is a very big Y stent, the dynamic Y stent, Y stent. We use one of these in the past in a patient with Munier-Kuhn. Maybe I can show you the video. So this is a Y stent applied in this patient. You can see that it's very reinforced with the metallic rings, but it's very difficult in the Munier-Kuhn with the tracheomegalia to have a long-term efficacy, and cause also granuloma, as you can see. And the other problem that we had is the obstruction of secretion. And after sometimes 6 months, the completely fracture of the posterior wall of the stent. It was very, very difficult to remove this stent. For the cuff, a very, very strong cuff, had broken the stent. So it's not easy, but now if the recommendation are this, if after positioning the stent, to evaluate if there is an improvement, if there is not an improvement, to go to other treatment. One proposed treatment is laser with the objective to devascularize and cause a fibrosis to reinforce the wall, the posterior wall of the trachea. There are very few studies. There is this study, Italian, French study, but not already published in 50 patients with and they give a laser posterior with the low power stent in the posterior stent, and they had good but short-term results. So it's a very difficult to treat pathology. Now we have 2 studies in the animals with argon plasma coagulation and with other thermoablative techniques, and we hope to have in the future demonstration also in human. But now maybe the only efficacious treatment is the surgical treatment with the tracheoplasty, with the external reinforcement, or as you can see here, to reinforce the posterior part of the trachea. So it's a difficult. It's difficult, but it's very important to diagnose and to try to treat this patient. Another possibility in patients with COPD and ADAC is the reduced intrathoracic pressure with valves, especially with the valves, with the Zephyr's valves. What is the future? And I conclude with this. The PBM is multi-phase equity. We need a very big experience of, especially for interventional pulmonologists. It's very frequent. 1 out to 5% of patients with history of chronic bronchitis, and multiple therapeutic options without evidence-based medicines are proposed, and the future will be laser or other superficial treatments. It's a matter of interventional pulmonologists. active or bioresorbable stents, bronchial lung, endoscopic lung volume reduction, and tracheal replacement. Thank you very much for your attention. Yeah.
Thank you very much, Professor Leonardo, for this nice presentation.
May I ask you if you have experience with in tracheobronchomalacia or in EDAC, in the tracheodyskinesia? No. Maybe
I might do the laser. I might
with
do
laser. No, with laser, no. And with stent.
You do the laser.
With stent,
the zigzag
stent, you have
laser.
experience. Yes.
Yeah.
Yes.
You do the zigzag
Good experience
laser.
or not? Very difficult to manage
it's
the
limited.
stent in this pathology.
It's
Yes.
a limited cases.
Yeah.
I want to know your experience in the demo stent. After how many months do you leave it? Do you leave it for 6 months, 1 year, 1.5 years, and then remove it? Some of our experience when they remove the stent after even 6 months, 1 year, it recollapse and we need to re-input the stent once more. So once the stent is put, I think in most cases, it is for life. Because when you remove it, it collapses.
Yes.
What about your experience in this area?
Yes, the same. The same. For example, the patient that I showed before with the Munier-Kuhn syndrome died after 1 year after the positioning. But it was a palliative treatment. It was a palliative treatment. Yes.
But some in literature say that it is easily removed after 6 months. This is right, that after 6 months you can remove the stent for patient with for post-intubation tracheal stenosis, and you put a stent in post-intubation tracheal stenosis, the complex type.
Yeah.
When you put a stent in this patient and you remove it after 6 months, the same stenosis appears once more. When I read in literature, I found that only they remove it after 6 months in some papers. Others say 1.5 years. But in real practice, I cannot do this in our series
not before 1 year. Not before 1 year. No.
How many percentage that you succeed in remove it after 1 year and it's completely patent? You do not need to put another stent later.
Yeah.
How many percent?
My experience is anecdotal, but there are some very big experiences also in Italy of Professor Cavaliere in Brescia that.
I'm sorry that I cannot make it in person to Cairo. I hope I can do that sometime in the future. The topic given to me is diagnostic peripheral nodule with 2021 conventional cutting edge and combination techniques. In the next few minutes, I'm going to cover this incredibly important topic under a few headings, because this is a real challenge. Peripheral nodules are detected in increasing numbers thanks to various screening programs and other indications for CT scan of the blood, where nodules are picked up incidentally, such as when you perform a CT coronary angiography. We are all going to face the challenge as to how we get to the nodule and make an accurate diagnosis and make even have to plan therapeutic approaches to these small nodules that are picked up. There are a number of approaches that have been taken over the years. For instance, fluoroscopy-guided transcontinuous aspiration, CT-guided biopsy, recently linear EBUS, radial EBUS, and other new techniques, all of which I try to cover very quickly in the next 15 to 20 minutes. Conventional sampling approaches that have been tried have included fluoroscopy-guided transcontinuous biopsy. However, this has been rather disappointing as far as diagnostic field is concerned, varying between 18 and 75%. And when it comes to lesions which are smaller than 2 centimeters, the diagnostic field plummets to under 20%. So this is how we have over the years attempted fluoroscopy-guided transcontinuous lung biopsy. The problem, though, is radiation, besides that, cost and resources, the fact that only larger nodules can be approached, and of course, this is a two-dimensional view that results in a low diagnostic having said that, it is a simple technique and it's worked in some situations. You don't have any other approaches available to you. CT-guided transbronchial lung biopsy has also been tried, but as you can appreciate, this is rather expensive, and availability and logistics of CT being used real time, inconvenience, the operator and assistant can also be irradiated besides the high dose of radiation to the patient. It doesn't need time consuming, and it's not real time mostly because you will check the position as to where your instrument accessory is, and sometimes it can be away from the lesion and then you have to irradiate the patient again. So it's not practical really, and therefore it was tried but given up very quickly. Linear reverse, as you know, is used extensively and it's the most evidence-based technique available in bronchoscopy for staging and diagnosis of lesions which are in contact with the tracheal bronchial tree. And this has been extended also for use within the esophagus and to take samples from peripheral lung lesions. Peripheral, as you can see, the lesions come in contact with the esophagus or even in contact with the bronchial tree, you can potentially access these and take biopsies. And this has been made possible further with the use of the second generation linear EVA scope, which is smaller, 6.6 millimeter in diameter versus 6.9 millimeter, the original scope, and also the fact that the ultrasound probe is shorter and smaller, and that allows you to go further into the bronchial tree and thus access lesions which are within the lung vertebra. The angulation of this scope has also helped and allows you to go, for instance, into the left upper lobe and other parts of the bronchial tree where you could not have done with the original EVA scope. Another innovation has been an even smaller, thin convex probe at EVA scope. And this probe is still under evaluation. It has been tried in one or two studies, early studies. What it does is provide you a greater degree of angulation compared to even the second generation EVA scope, and you could go into the lower bronchi, even into the segmental bronchi, as shown in this initial study. But this scope is not available as yet, so you've got to watch the space, and hopefully this will provide greater access into the lung parenchyma. Now, coming to the next technique which has been used very extensively, and that is the radial EBUS mini probe. This is, in fact, the most widely used technique for peripheral lung sampling, and it's a simple miniature ultrasound probe which is passed through the working channel of a bronchoscope to get to the lesion, and once you get to the lesion, you see appearances like this where the mini probe is in the very middle of the lesion, what is called as a concentric position, as opposed to eccentric position, which provides a slightly lower diagnostic field. And you can see here the bronchoscope and the mini probe is being passed until you get to the abnormality. Once you get to the abnormality, you have the option of removing the tiny mini probe, leaving the guide sheet in place, and taking biopsy, brush samples, etc. There are certain factors which affect the diagnostic field here. One is the location of the probe in the lesion, where if it's concentric in this fashion, the diagnostic field goes up to 80%, and if it's eccentric, it drops to around 50%. The other factor when planning a mini probe, radial EBUS mini probe, is to check whether what we call as a bronchus sign. We can actually see in the lung windows that an airway is going into the lesion. And if it is the case, then you're more likely to get a concentric position and a higher diagnostic field. In short, this technique is very useful when the lesions are greater than 20 millimeter in size. They are not exactly too far into the lung, although they are in the lung parenchyma. bronchocyte, as I mentioned, location of the probe in the lesion, presence of malignancy. Solid lesions give us a higher diagnostic yield than ground glass lesion. You must remember that certain lobes are more tricky to get to. The upper lobe often provides a better diagnostic yield. This is partly because what we call a CT to body divergence, which applies even for navigation technique. One of the advances in this area is the use of a very flex needle. We routinely use it in our practice, where this needle, 2 centimeter length, gives us a higher diagnostic yield than with the biopsy samples that we use. More recently, transbronchial cryobiopsy has also been used after performing radial EBUS mini probe and locating the lesion. Use a cryoprobe to get larger biopsy samples as shown here. The next technique is electromagnetic navigation. This has been around for nearly 2 decades now, and this is a technique where a reconstruction of the CT images is used, a specific planner, and then there's a magnetic board where the patient has to lie on, and after registration of the bronchial anatomy, a sensor probe, magnetic sensor probe, is helped to guide you towards a lesion within the bronchial tree, and then allows you to take samples. However, this is an expensive technique. Both the whole system as well as each of the accessories, the magnetic probe, the sensor probe, etc., is rather expensive, and therefore this has not been used as extensively as it was promising to be originally. And despite all this, the diagnostic yield is not huge. I've mentioned about the CT to body divergence, the respiratory movement, and also although there is some data and there have been advances in this technique that have made it better, still it's not as widely used, certainly in the UK and Europe as it was thought to and hoped for before. The next technique which is available is virtual bronchoscopic navigation. This is where you do not use a probe, it's more like a planner, and the original one which became available was what is called the lung point satellite system. And building on that, what you do is to take more than 200 slices following a particular protocol with a CT, and that is used to reconstruct the images and get a plan as to how to get to the periphery. And you get 2 or 3 paths that are provided to you, and this can be this is adjacent to your actual live bronchoscopic image. Once you get into the carina and beyond into the lobar bronchi and the segmental bronchi, the planner then guides you to turn left and right and get to the segment until you are really close to the lesion, and then provides you a suggestion as to the best entry point to get into and take a sample. Now, all this is important because whilst planning and getting to the lesion, you can leave a catheter there and potentially use therapeutic techniques to treat nodules, such as being demonstrated here with microwave ablation, similarly radiofrequency ablation, bronchoscopic thermal vapor ablation, and so on are being studied at the moment. So that's the idea of getting to the periphery. Now, virtual bronchoscopic navigation has been combined with EBUS and with fluoroscopy, and in an RCT published nearly 10 years ago, it was shown that the diagnostic yield with VBN, particularly when the lesions are smaller, the diagnostic yield was much higher than without virtual bronchoscopic navigation. So remember, this uses VBN with EBUS and fluoroscopy. So fluoroscopy time also needs to be taken into consideration, but it looks like a promising technique. Furthermore, smaller and smaller bronchoscopes have become available. You will remember that most of our bronchoscopes that we use are between 5 and 6 millimeter in outer diameter, but a slimmer scope became available, which is 4.9 millimeter, and now the smallest is the pediatric bronchoscope, which is used. So ultra thin bronchoscope is another option to take samples with. And this ultra thin bronchoscope has also been studied in a RCT from Japan, Asano and colleagues, showing that if you use ultra-thin bronchoscope along with VBN, potentially in, say, for instance, in the upper lobe, your diagnostic yield can go up to well over 80%, and when you do not use VBN, then it falls again. So ultra-thin bronchoscope is another technique. All these techniques that I've mentioned so far have provided a diagnostic yield of 70% or just above 70%, and very low risk of pneumothorax compared to CT-guided biopsy. So still, 70% is perhaps not sufficient considering the amount of time, effort, and resources you're spending on these techniques. And in the real world, the American Acquired Registry showed that the diagnostic yield is not as high as demonstrated in those studies and meta-analysis. This you need to remember, and therefore there is a need to look at other techniques as well. One such technique is bronchoscopic transparenchymal nodule access, BTPNA. This is an advance on the lung point, which you saw earlier. This is called the Archimedes system, where besides planning, in addition, you can create a channel using a needle, dilating of the balloon, and then that channel is used to put a guide sheet through very carefully whilst ensuring that there is no impact or there's no side effect on the vasculature, and through this you can go into the lung. That's why it's called transparenchymal nodule access. It is not following the anatomy of the segmental or subsegmental bronchi, but going through into the lung, avoiding blood vessels, and then taking biopsy samples. So this is TPNA, bronchoscopic TPNA. A great deal of excitement now, most recently, is on these techniques, which I'm going to show you now, which is, first of all, robot-assisted bronchoscopy. It's become almost a topic in its own right, but I'm just giving you a very brief overview of the headlines. Robot-assisted bronchoscopy has been studied. There are two types of robots which are available at the moment, the Monarch platform and the Ion platform, and this helps us to get through to the periphery and biopsy, and this potentially in the future will help us also to perform therapeutic bronchoscopy and deal with peripheral nodules. Another technique which is becoming increasingly popular is the use of cone beam CT with augmented fluoroscopy. This is a procedure where there is an intra-procedural cone beam computer CT imaging, which is used to assess and confirm the location of your biopsy devices and accessories, and potentially use augmented fluoroscopy. And what does this look like? This is the actual cone beam CT, and this is being shown, one of the types of cone beam CT, and being demonstrated in the Netherlands, where routinely with the cone beam CT guidance, bronchoscopy is performed, and then through and use of augmented fluoroscopy, you can get to the periphery of this nodule. And this is again attracting a great deal of interest and a topic in its own right. In the interest of time, I'm only giving you a flavor and overview of the sort of techniques which are available. Then you have bronchoscopic needle-based confocal laser endomicroscopy. This is a technique which is used in where probe-based confocal laser endomicroscopic imaging is used to guide you to the periphery and potentially take samples as well. So just to give you an idea, in the current world, despite all these techniques available in the real world, what we do at our center. This is a patient who has been referred from another hospital with a peripheral abnormality and opacity, as you can see, high up in the left upper lobe, and a PET scan was performed confirming that the lesion is FDG avid. The patient has emphysema, so quite severe emphysema, so CT guided biopsy is not an option, and this lesion is away from the airways, so linear EBUS is not an option. So what we do is one radial EBUS mini probe, then fluoroscopy to confirm that there is no risk of pneumothorax, and then take biopsy. So the combination of bronchoscopy, radiolibus mini probe, and fluoroscopy helped us to get to the lesion. So just to conclude the presentation, this particular topic is of tremendous interest because there is an increasing demand with increasing incidence of nodules, peripheral pulmonary lesions. A variety of promising techniques are available. They are all improving, but it's still suboptimal as far as diagnostic yield is concerned. Combining techniques is probably better, but increases the cost. In the future will probably be with ultra-thin bronchoscopes, radiolibus mini probe, smaller EBUS TBNA scopes, virtual bronchoscopic navigation, and maybe even, if you can afford it, more expensive techniques and tools such as augmented fluoroscopy and cone beam CT, so that eventually you can run a one-stop shop where you make a diagnosis and treat the patient appropriately and very quickly with something like microwave or radio frequency or other emerging techniques. And all this requires a multidisciplinary effort involving all the players in your bronchoscopy suite and radiology and everybody else involved in the care. Thank you very much indeed for your kind attention.
Thank you very much, Professor Munawir, for this nice talk and very comprehensive presentation. Now we introduce